We are, yep, all good to go. Okay, well, welcome everyone, and a very warm welcome to what is our last session, but certainly not our least, action-packed session this evening. My name's Trevor Sutton. I'm a member of the Independent Advisory Group, which is chaired by Peter Piot, and until recently, the Australian Deputy Statistician. And I'm your moderator for this session. The topic for this session is appropriately titled The Next 20 Years of GBD. Now, as I would like to think of it, actually more appropriately as Infinity and Beyond. Now, having listened to Richard's talk yesterday, I'm actually now basically re-engineered that to Guardians of the Galaxy. All jokes aside, our main presenter is Chris Murray, who will, I guess, really doesn't need much of an introduction as the director of IHME and founder of GBD, indeed the whole approach to GBD, and much more, including his untiring commitment to innovation, the scientific approach, and someone who's had the sheer guts and determination to create what I think we'd all agree is a global public good that GBD has become. And I think we'd all absolutely take our hats off to Chris's absolute commitment, and what we see today is very much about his drive and leadership. In terms of our discussants, we have three discussants for this session. It comes as no surprise. Who will no doubt respond to Chris's presentation and also offer some of their own insights, particularly with respect to how they've had opportunities to use GBD in their own work. So first is Natasha Azzopardi-Muscat, who is the President of the European Public Health Association and currently works as a consultant in the Public Health Medicine at the Directorate of Health, Information and Research in Malta, having previously held senior positions in the Ministry of Health, including Chief Medical Officer. Our second discussant is Joshua Salomon. Joshua is a Professor of Medicine in the Centre of Health Policy and Centre for Primary Care and Outcomes Research at Stanford University and Director of the Prevention Policy Modelling Lab. He's also been a contributor to the Global Burden of Disease Study since 1994, so he has a long history. Our final discussant is Ed Whiting, Director of Policy and Director's Chief of Staff, the Wellcome Foundation, which he joined in September 2016. He's worked in several Whitehall social and financial policy departments during his civil service career, including Her Majesty's Treasury's Financial Stability Team during the 2008-2009 financial crisis, which I'm sure was a very challenging time to say the least. He was most recently at 10 Downing Street as Deputy Principal Private Secretary to the Prime Minister, leading on public service. So, without further ado, I would really like to welcome our presenter, Chris Murray.
Great, and good afternoon. I, as apparently an accountant, shall now talk about where we're going with our accountancy work. So roughly speaking, what I'd like to touch on are the following directions that I believe we should be going. Some of them are things that we are well underway, and some of them are a little bit more speculative, but really reflect, I think, a mixture of both how to make the science of what we do stronger, but also to think about how we can use the GBD to go into or leverage the work that's gone into the GBD for extended uses, whether it's around health systems or data quality or data gaps or supporting policy dialogue. So first, and I think probably the most important, is for us to continue expanding and deepening what has become this collaborative model for measurement that is the GBD today. This graph, which really talks about formal, i.e. in the sense of formalizing a network of collaborators, shows the exponential growth, actually, of collaboration. And I think we're starting to think about what does it take to sustain that, but also to deepen and support effective collaboration. I think that's going to take some technical innovation, because it'll be very hard for even the task of making sense, analyzing, writing papers and reports as we continue to grow, which I expect we shall. So certainly a challenge, but a direction that we will unquestionably pursue. Of course, we will keep adding diseases in each cycle of GBD. For those of you who are collaborators, you know that we put out a call for suggestions. We ended up, based on priority, availability of data, for 2017, for example, to add a series of causes from NFLD, NASH, right through to splitting up diabetes into type 1 and type 2 diabetes, and a number of other suggestions. And we have a list for GBD 2018 and on, and I'm sure that will continue. But something new on the cause list is the idea that we should more formally assess intermediate causes that have clinical and health service implications that people ask us for, like sepsis. And although we think of sepsis not as a true underlying cause, that we will want to keep track of these intermediate causes for many reasons. And so we will start that process even now in GBD 2017. I think we've heard from Peter Piot and from a number of people in the last 2 days about the desirability of expanding our notion of risk factors. Duncan Selby, in the session that we just heard, talked about bringing together social determinants and the risks that are there in the GBD. And we really want to bring that in directly into the quantification of upstream risk factors or causes. We will start in this cycle with educational attainment and continue on from there. Perhaps more importantly, we recognize that there's a big gap in what we're doing around climate. I think Richard Horton had a call to action yesterday. We've certainly been hearing that and paying attention. And we will progressively incorporate more of the climate-related and other environmental and planetary boundary risks. The first up will be temperature. That'll be very important as I talk about forecasting towards the end of this presentation. And we started, and we haven't released yet, but as you know, we've started to try to quantify a different type of risk, that is low coverage of interventions. And we started with some of the vaccinations this year, and we will plan to expand that progressively over time. I know there's participants that have been drawing attention to this for a number of years, and that's something that I think will be an important addition. Now, I think one of the things that characterizes this enterprise over the last 20 plus years has been constant innovation in methods, adopting from other fields their methods innovations, and from within the people who've been working on the GBD, many methodological innovations. And of course, we expect that to continue. We don't want to view the science and the toolkit that we use to be static. We want it to always reflect the best available, both evidence, but also the best available methods for analyzing the evidence. It's a long list, even just for GBD 2017, of things that we would like to improve. Just to flag one that I think is coming, we're starting to test it in the next cycle. It will have a rather large effect, we believe, is the shift over to a new version of our disease modeling meta-regression framework, DISMOD, to one that allows one to recognize cohort age time effects in much greater detail. And that's something that I think, as it does come to fruition, will actually have important effects on both the estimates, but also on uncertainty for many of the outcomes we try to track. Something that's a little bit more, it's starting to happen, but something that I think we will want to embrace and explore and try to do a lot more of, is to try to directly use electronic medical record data and or claims data in many different countries where it's available and which covers enough of the population that exclusion doesn't make the data hard to interpret. There's a lot of work that has to go into using this type of data in the future, but it's clearly an important direction as we look ahead, with many people volunteering or suggesting that there are individual level data sets that could enrich the GBD. Now, one of the ones that we've had a lot of discussion about, because it's already happening, is more local GBD. And I think we are, of course, pursuing this. We have, with each cycle of the GBD, and this will continue into the future, we have been adding new countries. So in the next cycle, Ethiopia, Iran, New Zealand, Norway, and Russia will have first administrative level breakdowns. Or in the case of New Zealand, it'll be Maori, non-Maori populations, so not geographically based, but ethnicity, race based. And that's a direction that will undoubtedly continue. But as you heard in the session before, we've even seen some examples used by Steve Lim. We've also been pursuing in two ways even more disaggregated analysis, using signal-to-noise processing type methods, the so-called BYM, random effects type models, to analyze data that's available at the county or even the sub-county level. And then the model-based geostatistics approach, where you saw Bill Gates show a map around malaria for mapping diseases at a pixel level. And yesterday was the publication of our work led by Simon Hay and colleagues of mapping child mortality at the pixel level in sub-Saharan Africa. Some examples of that, for those of you who have not followed this application, Laura spoke about it, but here's that an example of using this signal-to-noise processing methods to try to isolate by county in the US over time and year every cause of death, every GBD cause of death for which is important in the US. And what's interesting is, as Richard Horton talked about, there's a form of discovery science here. There are patterns that show up, this is liver cancer, that really beg hypothesis generation. You know, what is going on in Texas? What is going on in other parts? And when you look at the trends, what's going on the West Coast of the United States with these huge increases in liver cancer? And of course, there are a number of different explanations around hepatitis C and others, but it's just an example of this power of local analysis, and I think the methods have sort of come of age. And as Laura mentioned, we are now able to bring this down to units of 2,000 people, albeit with considerable uncertainty, but nevertheless finding meaningful patterns with a tendency of these methods to underestimate true variation and not overestimate, which is something to bear in mind. An example, as I mentioned, of the model-based geostatistics approach is the mapping here of child mortality that was published on the 25th. And this is pixel-level analysis over time of child death, under 5 death rates in sub-Saharan Africa. And it's an example of what is much more to come as we expand into both risk mapping and infectious disease mapping for a number of leading infectious diseases. And I think we've been starting to think, you know, not 2, 3, 5 or years ahead, but even farther, which is how far can we go with this, right? How far, what's the limit that's sensible in pursuing this local measurement? And I think in some ways, I've been trying to convince people that our ultimate goal should be to no longer even estimate for geographic areas. We should try to produce estimates for every individual on Earth. And where there's actually direct data, electronic medical record data, we could use that for the individual, and where there's not, we use the models to generate a plausible assessment for somebody in that location and various variables that describe them. There's a lot of challenges in doing that. privacy being a preeminent one. This is technically feasible. We could do this if people thought it was valuable, and the sort of push towards the individual level data continues in the direction that it's been going. And you can imagine a huge array of very practical applications of this, whether it's allowing people to explore any association without having to pre-think what people want to know, whether it's spatially or related to various socio-demographic and economic factors, and as tools at the clinic level, where you could have, starting with an empirical prior as somebody is seeking care, and then, in the usual way that physicians practice, revise that through history and examination and tests. So I don't know if we'll end up there, but it is something worth thinking about as we look ahead to how far we should go for subnational assessments. A direction that we've started to pursue more in the GBD 2016 work is explicit metrics around data quality. So we introduced explicit reporting of completeness of vital registration, our 5-star cause of death quality rating system. And we imagine that in the case of GBD 2016, the 82,000 sources that we use, and if we count covariates, well over 110,000 sources that we use, trying to come up with quality metrics for each class of data. Some of these are harder than others. But as we go ahead, both assess the quality of the data that's there in each type, and then that puts us in a much stronger position to use the GBD and the database that's being created to support the GBD to identify data gaps, which we heard lots of interest and discussion during the course of the day. Another direction that we have been going is taking the GBD and using it to measure and monitor aspects of the health system. We've looked at SDGs, we've been reporting on universal health coverage in a sort of more robust way this cycle. We started to report on healthcare access and quality using mortality amenable to healthcare. And we've actually started to expand the scope of the GBD to encompass health expenditure analysis. And this is a direction that will surely grow. And as we heard Bill Gates talk about this morning, the power of putting information on spend in health systems and human resources together with the outcome data can be very great. And no doubt we will do this more as we look ahead. Now, I think we've heard a lot of discussion in the previous session, in yesterday, about how we make the GBD even more effective than it has been in supporting policy dialogue. And for those of you that have not noticed, we have innovated on a number of ways to communicate, and the latest one is mobile apps. In the App Store now, there's a health atlas, and that gives you GBD-based profiles for countries in 4 languages, Chinese, Spanish, Russian, and English. You can download it in the App Store and in the Android store. So it's there now. And it's a taste of where I think we need to be going, of thinking about really diverse ways to communicate information and get into the hands of people who can use it and act on it. Now, probably the biggest new direction for us is the scenario work. And Bill Gates talked about the World Progress Report. The first sort of public use of our future scenarios in its current iteration was in what Bill showed for 18 indicators that they used in the World Progress Report. Now, for those of you who remember, the original 4 papers, then we're celebrating 20 years since the publication of those first 4 papers in The Lancet. One of them was about forecasts. And Alan and I, with help from a number of others, made a very simplistic model to forecast the burden. And that's actually the paper, the original GBD quartet that's been cited the most, as it turns out. And I think part of that reflects people's great demand for some quantitative notion of what the future might look like, because there's lots of investment decisions that require a glimpse into the future. Anything with a long-term payoff, whether it's new technology, training health workers, building infrastructure that lasts for a long time, or even just identifying new threats for which we don't have solutions yet today or policy strategies today. So there's lots of reasons to forecast. The marketplace, if you will, the intellectual marketplace has told us that forecasting is important. And we've been building alongside the GBD, with support from the Bill and Melinda Gates Foundation, a forecasting platform. And that is now getting to the point where we're ready to take the GBD results and at the country-by-country basis, run these into the future. But in the 3 years that we've been working on this, we've gotten a tremendous amount of useful feedback and learned about the experience of using scenarios and forecasts in other fields. And that's led us to make lots of major changes to how we think about developing scenarios. What we have ended up is coming up with 3 base scenarios that we'll produce and keep up to date in every year and run them out into the future, at least 25 years, perhaps more, as some of the climate people have asked us to do. We'll have a reference scenario, which is what would happen, not what will happen, but what would happen if the independent drivers in our modeling, which are all the GBD risk factors, income, education, fertility, and healthcare access and quality, continue their trends into the future, and if the known causal relationships between those variables as observed in the past through cohorts, trials, and in the case of the socioeconomic variables, statistical models, if those relationships continue into the future. So that's our reference scenario. Not what will happen, but what is most likely to happen given what we've seen in the past. And of course, as Bill Gates said, it's not a crystal ball, but it's a useful reference point, thus the term reference scenario, for thinking about how policy and investments can change our trajectory. And as Bill showed, we produce a better and worse scenario, which is very simplistic. It's saying, what if everybody moved up their game and got to the level of the 85th percentile on all the independent drivers of health, as 85th percentile of rates of improvement for all the independent drivers, and the worst scenario is the 15th percentile. And then we produce those, and that gives you the red-green range that you saw in the graph. Of course, having built a forecasting platform with causal associations for, about 90 variables, we can also relatively easily create bespoke scenarios for all the variables that are in the model to start with by rerunning the process with different values, for example, for smoking for a given place. Now, the independent drivers are itself turns out to be extraordinarily interesting and useful for policy dialogue, even before we go from the independent drivers to the outcomes. So on the top is our simple forecast for smoking prevalence. The blue is reference. Red is if everyone goes to the 15th percentile rate of change, which is actually increasing for smoking. And the 85th percentile is green. And of course, at the global level, that means there's quite a scope to either bend the curve on tobacco or actually slip in terms of progress. We also found out that we couldn't use income predictions from the IMF or the World Bank because they only go out 6 years, and then other producers of income forecasts don't go out for all countries. And so we've had a separate research program to develop forecasts of income per capita. And what's important from that, both for income per capita and also for poverty, which we're also forecasting, is that on current trends, we are going to have many poor people still in the world, and this is the $3.10 threshold, slightly higher than the $1.95 absolute poverty threshold. But the message is the same, is that the number may go down globally, but the number on current trends in absolute poverty in sub-Saharan Africa will go up. And that's because of demographic change combined with slow economic growth. And that's a sobering reflection that comes from looking at these numbers, that even though the world is making progress, we see that in the GBD, we run that out into the forecasts, there is a disadvantaged group that could well not, and an increasing number, particularly in sub-Saharan Africa, that will not be better off, even in 25 years into the future. And when we turn this into metrics like life expectancy, we find, because of threats like obesity and slowdowns in progress in some areas, that the global trend for life expectancy may likely slow down, and that we could actually make no progress if things really go wrong on all the independent drivers if we shift to the sort of regress level or the 15th percentile. And you can do all sorts of things by having a full set of burden of disease forecasts. And I'm showing at the global level, but we have these and are going to produce these at the country level, and we'll start to produce at the subnational level once we sort of finalize the methods and start to release these. That you can decompose change in life expectancy, shown here between now and in 25 years in the future, by cause, what will drive improvements, and how different is that trend between the worst scenario, the reference, and the better. Now, the power of this is not to say this is a crystal ball, but it opens up a really interesting policy discussion with many actors. And in the sort of early rollout of this, we did some work with the Department of Health in the UK. We've had presentations and discussions that have followed from the Gates Progress Report, and we've test marketed this on a number of groups who are interested in these sort of tools for planning. As long as we're honest about what it is and the uncertainty that are around these different scenarios, I think there's tremendous potential to use these tools to trigger important policy discussions in different countries. And they'll be different by location. So, I've given you a flavor of all that, not all, but all the things that are sort of high on my agenda for the next 20 years. I think that the nature of organizing a large collaboration is that we will, as we did in this cycle, be looking to the community, the GBD family, to also help steer actually where we go. And these are just a set of ideas that I think some are already starting to happen, and many new ones will also come as great ideas emerge from our colleagues. Thank you very much.
So thanks, Chris, and Chris has given you a pretty good view of some of certainly the technical improvements that they're considering, and indeed have made some real progress on over the last few years indeed. I'd like now to invite our discussants to reflect on some of the things that Chris has presented, but also bring their own insights and experiences in particular where they've got experiences where they've used GBD to influence policy, because we know that facts are not always around the policy decision-making table, and one of the big challenges is how do we make sure that those facts actually do get a seat at the table. And I think that's one of the big challenges going forwards for GBD, is to what extent does it invest in continuing to improve the technical aspects of GBD, which has been obviously one of its great characteristics and compelling attributes, but I think there is a more strategic, discussion around if you had 5 extra discretionary dollars over the next, say, 5 or 10 years, how much of that would you invest in continuing that technical improvement? Being a bit naughty if I was to call it polishing the stone, because there's a lot more to it than that, or continuing to polish the stone. And how much of it would you actually invest in the what I would call in the engagement and social marketing of the product that we have as GBD, and you could push that right down to the advocacy end. It's not an end that I personally would support, but you could go as far down to that advocacy end of the spectrum. But what I'm really proposing is there really is a choice between how much more technical improvement do you do versus how much do you actually invest in greater partnerships and basically what I would call the social marketing of the product that GBD is all about. And so with that on that note, I'll pass over to Natasha to talk about or respond to some of what Chris has said, and also her own experiences with GBD.
Thank you, Trevor, and thank you, Chris, for really pointing out some important elements that are forcing us, I suppose, to think really about the future. But allow me to dwell a little bit on the past. And I just realized that actually my public health career this year is also celebrating 20 years with the GDB. And GDB has been somewhere there, when I have been working as a civil servant, as an academic, I've encountered GBD in various forms. At the very start of my career, I encountered GBD because my country, Malta, had placed 5th in the notorious ranking. And I suppose for many years we had a standing instruction to make sure that this was included in every official speech and release. And about 5 years later, I remember saying, you know, I think this has been overdone. Now can we please stop this? But as recently as last week, when the paper in the Lancet on the SDGs was published, I found myself once again being asked, for example, I mean, it was tweeted and retweeted by the Deputy Prime Minister and the Prime Minister because we did well again. And I found myself being asked to provide more information about why we were 14th last year and why we were 8th this year. And I said, well, actually, that's not important, but I suppose the information you really want and you should be looking at is where we're doing well and where there's space to do better. But it was a very important hook to engage attention, and I hope that there's an opportunity now to open a little bit of a dialogue. And I think the decision to focus on the SDGs, which somehow brings all of government in, because you've got the Minister for Foreign Affairs, you've got the Minister for Finance, it's really an important entry point for intersectoral action. And the fact that there's been a decision to have the publication on a yearly basis are both very, very important decisions that are going to be able to engage with policy in a greater way perhaps than has happened to date, merely because also because of the fact that politicians are very short-term and sort of immediate focused. So we can engage in a theoretical and academic discussion, which is very important, and is taking place in Europe at the moment, about how our health systems should look in the year 2050 and 2070. And I think this kind of modeling and scenario work is extremely important to try and get us to move a bit away from the crystal ball gazing and towards perhaps something which is a little bit more based on some kind of explicit methodology, albeit with all the caveats and uncertainties. So I think that actually, perhaps without knowing, there's already been some key decisions taken in the recent years that have facilitated this engagement with policy. And definitely, GBD is a very, very powerful tool. Also, I think it's in this unique position where you can say what you have to say, because, for example, again, within Europe, trying to have an exercise around health system performance assessment carried out by Eurostat or the European Commission is totally a no-go area for member states. So I think that IHME, with this global network of collaborators, has positioned itself very well to have this independence and authority and to be able to speak truth, but it's positioned itself in a way that it's able to do so because it's not part of an institution. And I think that's really important, and I would strongly urge that you retain that kind of independence as we go forward. So I think you asked us to reflect a little bit upon the scenarios and what could happen. Very optimistically, we could say, well, there's economic growth, we're improving education worldwide, everybody's going to have their smartphone, there's information on how to improve your health at your fingertips, so we should be looking at health improving and improving for everyone. There's loads of medicines in the pipeline and technologies, and it should all be going in the right direction. But unfortunately, there is much which threatens to challenge this vision. And a lot has been said over the past 2 days about the social determinants of health, about the environmental determinants of health. And I think realistically, we have to consider the bleak prospect that our children and grandchildren may well not enjoy the life expectancies that we've been enjoying today in the more advanced economies. And I think that what's happening in the middle income, lower income countries that are dealing with the double whammy of still combating communicable disease, whilst having huge inexorable rising levels of NCDs, could very much throw us into disarray. Furthermore, I think there are new challenges arising, and I think that we need to find ways to measure this, which is around lifestyle harming behaviors. Possibly this has got to do with the threat of not having a job, of being permanently in unemployment, as was referenced this morning by the World Bank. So then what do people do? Perhaps they turn towards lifestyle harming behaviors. We're seeing increasing flirtation, for example, with potent substances of abuse. And we're seeing a wave, for example, of legalization of certain substances which perhaps previously were less accessible. Some countries are experiencing increasing suicide rates, and I think that all of this somehow needs to be captured. In terms of perhaps a few suggestions for going forward, I'd invite the GBD to consider how they can integrate big data. Today, in those countries, I mean, this might help us even to overcome the inverse data law, which is that the countries where we need most data from are the countries which often have the least organized and robust data governance structures to have it. But practically everyone has a smartphone. And I think there are a lot of challenges to overcome there, not least the data privacy, not least also the imperfection around the data that can be collected. But I think we should be looking at trying to find a partner who would be willing to share all this data that is around from a public good perspective, basically. And I think that's something that we should be looking at. I'd like to see perhaps a little bit more case study work. There are a lot of methods which combine qualitative and quantitative approaches from the social sciences, using case study work, using MSDO, MDSO techniques, and that perhaps could help us also to look more into the future. And something else that was raised this morning, which is about the openness of the economy, the fact that we've got this ocean and we can't go back to small ponds and lakes. And I think that we need to be aware of this also with the GBD, particularly when we do work on health systems. Many health systems today are very much affected by this open and global market, both when we talk about healthcare workforce, when we talk about access to medicines and technologies. The rules are governed at a global level, as well as public health in general. I mean, there's a lot of the global commerce that is shaping people's health. And I don't know how one could go about doing it, but I get a sense that we need to start taking into account this interdependence somehow, because there are certain outcomes that do not depend solely on what national or regional governments are able to do, and therefore presenting these rankings, these indices, in a way that politicians perhaps sometimes feel a bit disempowered or a bit limited in what they can do, because there are factors that are beyond their control that are impacting on health outcomes and their health systems. And if there is some way we can find some way of including this interdependence in the work, perhaps that's something that we can think about for the future. To conclude, on behalf of the European Public Health Association, I'd like to commend the work that has been carried out. Our mission is actually to facilitate and activate a strong voice of the public health network in Europe by enhancing the visibility of the evidence. So I am very open to find ways in which we can work together. And this morning somebody said, I think, that scientists are not always the best people perhaps to present the evidence, to engage, but there are then platforms and associations that bring scientists and professional communities together, and that we can act as partners, and we'd be willing to act as partners to be able to be interlocutors in this field. And finally, I think 2018 is going to be a window of opportunity to put NCDs on the agenda, with UNGA in New York focusing on NCDs. And I would suggest that that could be something that you'd want to look at. Thank you.
Thanks, Natasha. Now I'd like to move on to Joshua.
Well, thank you very much. And let me start by saying that I'll offer a few comments, not as a policymaker acting on the information in the GBD, but as a longtime contributor who's been engaged in the production of the information. That said, I think Trevor's invited us to think about the different approaches to GBD, including improving the technical basis all the way to improving the communication and uptake of the information for policymakers. But I'll suggest, and my comments will reflect the suggestion, that I think in Chris's list, there's something of a middle way, which is not just to think about the strictly technical methodologic basis of the analysis, but also to think seriously about an expansion in the scope and content of the GBD to take on questions and bring analyses to bear that do bring the information a little bit closer to decisions that policymakers have. And so that's really largely the perspective that I will offer a few comments about today. Let me start by saying that I have been a contributor to the GBD over my entire career, the last 23 years, and so this really has been my entry point to global health when I started as a young research assistant. So I just want to say congratulations and thank you to Chris and Alan. Thank you to all of my colleagues in this room and outside who are collaborators on this enterprise. And I also want to say a special thank you to all of the young researchers at IHME, some of whom have spoken over these last couple of days, but many more of whom are simply making all of this happen. So, you know, when I look at them, I see smarter, more motivated, more optimistic versions of myself when I began this field. And so I would say that the future of the GBD seems to be in very good hands indeed. So over the past couple of days, we really have enjoyed a lot of very rich discussion and debate. And I think my take on these last couple of days is that this really does send the GBD off into its third decade with a great deal of momentum and excitement, but also with a very clear view of the profoundly challenging context that Richard Horton laid out for us so nicely yesterday. And in thinking about the conversations over these last 2 days, and this session really, I think, aiming to crystallize some of those, it really has been a persistent theme to ask how we can translate the tremendous public good that the GBD has produced into better decision-making in public health. And there's also been, over these last couple of days, some amount of consistency in the suggested recipe, a lot of which actually has focused on technical aspects, including Bill Gates's recipe as he reiterated it today, more data to reduce uncertainty around the estimates, shortening the latency time for the information to be updated, increasing the geographic resolution of the estimates. We heard a lot about that over the last couple of days, and indeed those were components in Chris's list that he presented in this session, as well as the final element in Bill Gates's list, which again we've heard quite a lot of, which is to engage more with political leadership to enact change. And there's been some debate about the relative attractiveness and importance of these different elements, but it seems clear that some combination of these is a likely path forward and is indeed a continuation of a lot of the progress to date. But I want to emphasize a slightly different direction that in my view has the greatest promise to amplify and build on the developments over the last couple of decades towards the end of producing more actionable info. And this has come up in a variety of different comments, but not necessarily with the same prominence as some of these technical aspects. And here's how I would describe the challenge. I do believe that the scope for the GBD to speak more directly to decision makers really does require that GBD expand, if not to say transform, from an accounting exercise, as it's been described quite a bit today, towards an analytic engine for asking and answering more direct questions about how to respond to health changes and to achieve impact. To date, GBD has been profoundly influential in defining priority areas for action, but it hasn't as fully aimed to directly address and compare the menu of specific actions that could be pursued. That said, I think we have seen in the recent rounds of GBD, and we see a lot of promise in Chris's wish list moving forward, what is possible. The most mature of these, I think, so far is the comparative risk assessment, which moves us from thinking about diseases and injuries towards thinking about risks, which are often more amenable to intervention, as David Blazes referred to it yesterday, where the rubber hits the road. And there are others, some of these on the horizon, some of these already taking shape. As Chris mentioned, the juxtaposition of burden information with information on health expenditures, the healthcare access and quality analysis with its focus on burden that's amenable to healthcare, the decomposition of burden into key drivers that so far include things like aging, population growth, risk reduction, and relating burden across countries to the socio-demographic index in order to identify exemplars and underperformers. But I would suggest that in addition to these developments, there are three concrete modifications and expansions of the GBD approach that I think will help to bring it closer to the goal of guiding action. And again, it's nice to have seen some of these in Chris's list, and perhaps what I will suggest is an endorsement of that, but in some cases, some small expansion of ambition in some of those directions. First of all, I think the objects of analysis, which are currently diseases and risk factors, should expand to more explicitly include decisions, intervention strategies, and policies. Again, some of that is already happening, and I'm looking forward to seeing that expand even further. The logical entry point is one that Chris mentioned, which is to add to the risk assessment risk factors comprising low coverage of effective interventions, and that is work that has begun and is continuing to develop, and I think is a welcome move in this direction. When we get to forecasts, as I will in a moment, and Chris spent some time on, I think there's scope for more thinking about interventions and policies as the objects of analysis, and that comes into a special clarity there. Before we get there, let me mention a second element that I think would be fruitful, which is more explicit modeling of mechanisms of change. So the last several rounds of the GBD, there have been especially large advances in statistical modeling of patterns and trends, but I do think there is a limit to how far we can go towards giving actionable guidance to decision makers based on statistical prediction, but that limit expands dramatically when we admit more explicit modeling of mechanisms of change. So if the current GBD provides largely an accounting framework that does acknowledge some of the key correlates of variation and change, especially distal factors like socioeconomics and broad demographic change, I think the GBD has been a little more hesitant with respect to more explicitly modeling some of the more proximal mechanisms of change. And again, the risk factor work, I think, is the work that thus far comes the closest, but there's lots more that could be done and can be done. And that brings me to the forecast, which I think is the thing that Chris spent the most time on, and it's probably the thing that has generated the greatest amount of enthusiasm and excitement here, and evidently in the discussions with policymakers. And that's the third element that comes in. And for me, this is absolutely the frontier for the next 20 years of the GBD, as many people, including Bill Gates this morning, have noted. And continuing on the theme that I've started, on the forecast, I suggest that GBD really does need to embrace not just uncertainty expressed as a distribution around the most likely future scenario or the reference scenario as it represents what would happen if past trends continue, but also to really go boldly into the area of expressing uncertainty in terms of discrete pathways that reflect different contingencies, different intervention choices, and different policies in both health and non-health sectors, as has come up in the discussions of the last couple of weeks. The glimpse that Bill Gates showed us and that Chris mentioned with the goalkeepers example is very tantalizing to look at, for example, what could happen under different funding trajectories. And Peter Piot, I think, said it well in calling for more of this work to engage more in the exploration of what-if scenarios. And to me, again, this is the most significant way that I think the GBD can speak more directly to policymakers. And I believe what I'm suggesting may go even a little bit further than what Chris described in terms of the range of scenarios, the reference scenario, the best and worst scenarios relating to independent drivers. And I think where perhaps I'm asking for even a greater degree of ambition is to connect not only to some of those independent drivers in the form of broad socioeconomic trends and health system developments, but also to much more explicit enumeration of different policies and strategies. Now, all of this will be difficult, undoubtedly. Modeling mechanisms, of course, invites the thorny questions about causality and how we know about causality and standards of evidence. This is already clear in a lot of the risk factor discussions. I think will be more so as we move into other broader mechanisms. There are challenges of a dramatically expanded scope. If we think about the expansion of scope in terms of adding diseases and risk factors, once we commit to thinking about potential policies and actions, we're into an almost limitless universe of different things that can be examined. But I also have confidence that tackling hard problems is what the GBD is all about. So let's welcome this challenge moving forward. In some ways, this is in the DNA of the GBD to take this work in audacious new directions. So let me sum up and end by revisiting some of the metaphors and analogies that we've heard over the last couple of days, which I've quite enjoyed. So
could you make this very quick?
Sure.
Because I think we're right on the...
Absolutely. So Teo offered us the metaphor of the developing child with the GBD now in its adolescent years. Mosen offered us the lovely analogy of the GBD as a river, not a mountain. We've heard from Richard that the GBD is a balance sheet for humanity. He has referred in the past to the GBD as the Human Genome Project for Population Health. Bill Gates this morning referred to the GBD as a blueprint for where to focus and as a report card on investments. For me, kind of in light of the argument that I've been making here, the metaphor that I like the best is one that we haven't heard today, and that is of the GBD as a laboratory, a facility for exploring and understanding mechanisms of population health improvement as drivers of past trends and current patterns, and for assessing how different decisions and policies might maximize the impact in the future. And so I look forward to taking on that challenge in the years to come. And thank you very much.
Thank you, Joshua. And we'll move right on to Ed.
Thank you. So I am the last new voice you will hear today. Congratulations on your stamina and your attention. They've stolen all of my material, so I will keep it very, very short. I'm also probably the least experienced and least expert person sitting on any of these panels, for which I apologize now and will not apologize for again. I'd like to say a word about context, because looking back 20 years and looking forward 20 years is a monumental enterprise. I'd like to also leave a few sort of specifics on the table, which, because of our lack of coordination around the panel, may echo some of what my fellow panelists have said. So firstly, on context, anyone opening your laptop screens today and booting up Google will see that today is Google's 19th birthday. So this means that GBD is officially older than Google. Please dwell on that for a second and think about all that has happened to Google in the last 20 years. GBD has had excellent longevity to get this far, and I think, saluting Chris and everyone else's work to do that. 20 years ago in the UK, Tony Blair was having his first conference as Labour Prime Minister. If you are a UK political anorak, like I try to be, you will have watched Jeremy Corbyn's speech earlier today, and you'll see that the political context has changed enormously. And it looks like if Jeremy Corbyn gets in, we may nationalise everything, which will be an interesting enterprise. Change has happened, change is happening enormously. 20 years ago, the Kyoto Protocol was signed. Today we have the Paris Agreement. In 20 years' time, the IPCC warned that we may just have passed the 2% threshold. We may reach that in 2036. And I think, we are many people have said we are at an inflection point around climate. And I think we need to sort of think about that as we think about what the next 20 years holds. 20 years ago, I was personally just starting my GCSE year. For me, as a LGBT youth, schools in England were not allowed to endorse my lifestyle. Today in Britain, as of 3 years ago, I could marry my partner, and I hope to one day, if I can convince him that that's a good idea. I'm working on it. However, thank you for your encouragement. However, people like me are imprisoned around the world in lots of places. We're not there yet. We've got a lot of work still to do. Looking ahead, and those people, of course, have no access to healthcare. So there is both a human rights and a healthcare impact that I think is up in my mind when I think about strides that we need to take around the world. When I look ahead 20 years, the people who are being the global health stewards at that time are the people who are in college now and possibly actually working in IHME right now. And the more that we can do to create a data-driven healthcare system, the better. Finally, 20 years ago, we as a community were only really getting to grips with HIV. Now we're moving from a narrative solely based around eradication, and I summarize enormously, to one that's based more on systems change, from the MDG to the SDG world, from eradication to looking at control of disease. So you look at AMR, you look at the NCDs, you look at mental health. These are things that we will not eradicate. We will not eradicate bacterial infection, I don't think. I'd be very surprised if we do, and bacterial infection will keep innovating to whatever antibiotics we throw at it. So a control world is a world we're moving into, and that's a real challenge for the data we need to understand what effective control looks like. There are also currently 400 million people still lacking access to health services, so we have some enormous challenges ahead. If the Chan-Zuckerberg initiative gets their way, in 20 years' time we may have eradicated all infectious disease, which would be a great thing. But what innovations will fundamentally accelerate progress and progress towards better well-being for everyone? And that's where the GBD forecasting will help us to understand and map those and prioritize those better. Why raise context and why start with context? Firstly, channeling Jim Kim, I think it's a challenge for all of us to keep that growth mindset in mind versus the fixed mindset and challenge ourselves to create growth mindset in the way that we lead and the way that we steward the global health system. Secondly, 20 years is a long time, and I think it's great to have a panel where we're thinking in that kind of perspective. The third thing, this is a messy world. Progress starts and stops. I would mention the river, not the mountain analogy, which I really liked. But this context is vital, and understanding this context is vital to accelerate, enable, or constrain progress. And again, IHME, goalkeepers, initiatives like that help us to do that. So some specifics to round off, and I'm sort of channeling Richard Horton in places again, partly because everyone on this panel has to mention Richard Horton, I think, as a contractual term. So I'm doing my bit too. Firstly, national level uptake. GBD provides tools for making the case, and what a case we need to make. So WHO figures, we need 55 billion more money every year to reach universal health coverage. We need 85% of that money to come from national governments. That is an enormous challenge, and GBD helps us to make that case. Secondly, we need to get to what the finance ministers read. I texted a former colleague from the Treasury overnight just saying, well, look, what are the most important things for you? If you had the GBD, where would you like to see its findings being reflected? He texted back and said, look, it's Article 4, the IMF, it's OECD work, it's the work of domestic health think tanks, it's some of the rating agency reports, but often the Treasury likes to think they're ahead of those rather than behind, and sometimes they are and sometimes they aren't. I think the key challenge is, where does this data need to get to? And I think whilst I agree that I don't want to create a dichotomy between improving the science and getting the advocacy out there, I do think we need to keep that in the back of our minds as we go. Secondly, broader measures. So multimorbidity, collecting data on AMR, causes of death, really hard because often it will make a bacterial infection may be the secondary cause. So understanding that and mapping that better is a huge challenge. Climate and food systems, we talked about that, movement of people. And how those broader measures can help frame decision-making. That's an area where I know Chris was in Wellcome a couple of weeks ago talking about this, expanding the GBD, and we certainly support that. Metrics on metrics. So I've mentioned already what reports is GBD getting into. If we're going to be data-driven about this, I'd love to understand more how the GBD is measuring its own impact and understanding where it's getting to. Similarly, on gaps, where are those gaps in data, and can GBD continue to be as transparent as it currently is about where those gaps are, and where there could be an alignment, for instance, in conflict states and in fragile states, or as countries in Africa start to diversify in terms of economic growth even more, Are there countries that are common, both poor performers and poor data providers? And how can we collectively get our arms around that problem? And then fourthly, and many people have mentioned this, but because I come from a research funder, I think I have the right to as well, greater use of what if. So for us, taking into account the development time that many products may need and how the world's context may change whilst that development happens. So help us to map whether putting 25 years into investing into a new vaccine for X or Y is really a good idea. Secondly, should that changing context, those big forces of climate, of food systems, of those other things that we really care about, should that change our priorities if we look ahead 20 years? We in Wellcome don't do very much of that kind of forecasting, and I'd like it if we would. And I think the GBD has a huge opportunity to help us to get into that and iterate and test and sort of manipulate those forecasts to understand better what we can do with it. I'd finally end, though, also on just a note of humility for everyone here. This is an amazing construct we have. The architecture of the GBD is formidable. As a non-mathematician, as a non-scientist, I'm blown away by what it can do. To make it credible and ensure that it's being sort of pitched and discussed in the right way, I think we need to hold on to humility that these are inputs, they're tools, they're best guesses, they're really good architecture and method, but they're just that, and they are not the final answer on what the world's going to look like in 20 years. They're inputs to help us make decisions. And I think it's really important when we talk about the GBD that we're both saluting and giving a lot of credit for what's happened so far, but putting it in the right context of the way we think about those decisions. Finally, though, I would say anything that GBD can do to sort of latch on to one of the phrases Barack Obama talked about at the goalkeepers meeting would be great. Better is good. Making things incrementally better is a good thing. We live in a very messy world, and there will be all sorts of forces that we have no idea about right now, some that we do, that will change what this world looks like in 20 years. Anything the GBD can do to help us incrementally make health systems better, frame the right challenges, prioritize investment is good and should be welcomed. So thank you very much for sticking with me, and I'm sorry that I am the last new voice, but I will now stop. Thank you.
Thanks, Ed. Now, we have about 12 minutes to take some questions from the floor. And please could you state your name and put the question as a question. Thank you.
So I'm Carla Makhlouf-Obermeyer. I have directed a research center at the American University of Beirut on population and health. My comments are not exactly questions, but I hope you will find them interesting. I think that in addition to the choice of being either the accountant or the advocate, I think there is a tremendous opportunity for GBD to be an interpreter of what is happening. And I think this is an important role for the future. I think many of the results of the GBD could be framed in ways that communicate to the public what might be happening on a global scale. And this touches eventually on the advocacy function that people are seeing. But there's also a way to engage with what are the forces, what are the drivers that are shaping these changes. And I think there is room for exploring further some of the potential threats and opportunities, which resides on the one hand in the knowledge, what does health literacy do for changing behaviors? And we know from previous theories of change that we attribute often too much to technological or policy changes, when in fact the reason for the changes were much older and were predated the results that we observed. So I think we need to think not just about engaging with policymakers, but thinking about the broader changes. So now I will formulate the question. Is there room for GBD to make alliances or add a dimension with people who are interested in formulating broad questions about change? in formulating specific research questions that can be investigated with this tremendous data that the GBD has.
Thank you. So, members of the panel, presenter?
I think, Carla, of course the answer is yes. The whole point of having the GBD data online is that we want people to be asking these sort of meta questions. I mean, within the study, as you know, we've started down this route that Josh mentioned of trying to quantitatively, understand the past. What's been the drivers? How much of it is broad development? How much of it is specific technologies? How much of it is risk behavior change, et cetera? And I think that's early days in that work. And I think we'll see more of that. But I think a good understanding of the past, of course, is an important basis for how we think about where we're going in the future.
Next question.
Salim Yusuf, Canada and India. I found the session interesting, and I found Chris's projections for the future interesting. But may I submit, there are two major omissions that I hope you will consider. The first omission is that the best quality data exists in the high-income country, and the worst quality data are in the low and the low-middle-income countries. I would hope to improve the health of the poorer countries where the health is worst. Could there be efforts that the GBD could do, working with national governments, to improve the quality of the data? And I understand all the reasons why data gaps have been filled with Bayesian modeling, but it also gives comfort to these countries that they don't have to produce data. So do continue with what you're doing, but if there is something you can do to build capacity, that would be great. The second is most people, and the GBD reports are incredibly opaque. Making them simpler would be useful, including its strengths and its weaknesses, and I have reviewed many papers for the Lancet, and I must say it's a very tough read. So I would request those two be in your priority. But I would want to end with one observation. We have had 17 speakers and chairs in the last 2 days, all from high-income countries. We've had 25 discussants, 21 from high-income countries, 3 from middle-income countries, and 1 from low-income countries. When you add it all up, it's 42 people on the podium, out of which only 4 are from middle-income and low-income countries. This does not reflect the balance of health need or health capacity in the world. It certainly is worse than your 80-20 gap. It's a 95-5 gap. My hope is 20 years from now, Chris, on that podium, we will be redressing it, and no more than 20 out of the 100 people will be white or male or from high-income countries, and there'll be greater capacity from people from middle and low-income countries. And I can see you nodding, and therefore you share my views. Thank you.
Thank you. What we might do is take a few more questions, and then I'll put the questions to the panel.
Hi, Rafael Lozano from IHME. I found very interesting these 2 days because thinking carefully, and thanks, Josh, for all your, the way that you guide us to think. 2 different decades, Chris. The first decade was a slow growth, and in the second decade of these 20 years was an exponential growth. So if we think how it's going to be the next 20 years, maybe we have to separate by decades, because now the bar is very high, and we are very data dependent, but also we are very technological dependent of the technology. So we go in that direction, and it's difficult to predict the future. My question is if we can get some insights from you about research and development. It is a long time ago at WHO, we did an exercise about prioritizing the most important areas of research. I didn't see that deep in this moment, and maybe we can start because we have to provoke countries to organize better the way to prioritize research, and maybe GBD is one useful tool. Thank you.
Thank you. I think I'll take one more, and then we'll put it back to the panel and the presenter. Yes, thank you.
Ami Banerjee from London. Thank you for an excellent panel. My background is in cardiology and health informatics, and the terminology that I find useful is the learning health system, where science, evidence, and care all use data, but there's immense wastage. And I'd like to ask the panel, particularly Chris, what are the opportunities to reduce the waste? So, for example, you mentioned using electronic health record data. There are problems of interoperability and coding between the GBD and electronic health record data. There are various health surveys that are cross-disease, cross-national, where we shouldn't be recreating the wheel. So what do you see in terms of reducing the waste in the next 20 years? Thank you.
Thank you. Okay, so I might quickly go to Chris, and then I'll ask the panel members to address some of those questions as well. Chris.
That was a good range of questions. Let me just touch on some more comments. On the last one, I think one of the core activities of the GBD has been mapping between very unaligned data sets. Just take cause of death, for example, mapping across the 50 or 60 national variants of the ICD, mapping over changes in the ICD over time, dealing with garbage coding. This sort of central notion of how can we post-process data to make it somewhat more comparable and allow for more meaningful comparisons. And I think we've started to make that around cause of death, for example, much more explicit. But what I was talking about around data quality and data gaps is that we need to do that for all the other types of data sources. And so there's a lot of potential around the GBD, given we're trying to capture all the evidence to try to inform those discussions. And it's more complicated than what Salim Youssef was saying when it comes to data sources that are available. It's not the case, it turns out, that data is always better in high-income countries and worse in low or middle-income countries. In fact, because of things like the regular demographic and health survey program, for certain outcomes, we actually have much better data in low-income settings. And then there are certain middle-income countries, I'm thinking of Brazil as an example, where because of a commitment to transparency and sort of data collection, there's actually better data than in many high-income countries. So I think it's why we need to look in detail and carefully and not have these sort of high-level generalizations about where data is good or where data is bad. And I think that's a core function that the GBD is starting to fulfill, because we are this aggregator of all the evidence. And it's the same thing around the interpretation of the evidence, which is we are trying to have a sort of rules-based, evidence-based approach to what's the available evidence tell us. And we hear, and we've heard it during some of the discussion, some individuals have very strong alternative views. And that's as it should be in scientific debate. But the function around the GBD is not to reflect one person's view, but to reflect the totality of the evidence that's out there, following some very clearly defined rules, and even let those rules that we use around evidence be contestable. And I think that's where we have to stay and keep going. And balance this trade-off between highlighting the strength of the data and the data gaps by things like our data quality measures, with providing decision makers with the best available evidence today, or visions of where we might be going in the future.
Thanks, Chris. Panel members, would any of you like to make a comment? Ed?
Just a few quick points. So on the data gaps and simpler reporting, I would say don't dumb things down. Let's have the 4,000-page Lancet there's a reason it's out there. Think more about micro-targeting, though, which is something that a discussant raised yesterday. What are the kind of, how are you going to equip the GBD to take on and be relevant to the people who could use it and make decisions with it, and keep testing how that is possible? And think about the priority messages from what you're sort of saying in the GBD. One from this, Africa's trajectory for 2030. I mean, goodness, I didn't know that until Chris came to Wellcome a couple of weeks ago, and it's transformed sort of my understanding of, what we should be doing and how we might gear our research in future. Secondly, on the 95 to 5 gap, amen, I entirely agree, and I would, talk giving seats up or whatever, but I think in Wellcome we're going through a journey where we're working on our diversity and inclusion strategy, which is changing the way that we're organising conferences in Wellcome and thinking about getting the right people around the table to have the breadth of insight and views that you need to make sensible decisions. It's changing Wellcome enormously, and it's a huge journey for us. Why does it matter here? We're also supporting a program to improve research excellence in Africa and transform that, because we know that if we invest in genome sequencing and understanding the rich diversity of the African genome, we're likely to end up with better drugs that are better geared for the populations who need them. So it matters for us enormously. Finally, what does it mean for GBD? I think the challenge is that we have an enormous centre of expertise right here in Seattle, but what needs to happen over the next 20 years is that centre of expertise needs to be spread and owned around the world. And the challenge should be not what is Chris producing in Seattle, but is how are the GBD findings emerging in places where you don't actually expect them, but where they can make a huge difference.
A quick 30 seconds, Joshua.
Sure, just some quick responses to a couple of the comments. With regard to the worry that the production of estimates will reduce incentives to develop new data collection. That certainly hasn't been my observation thus far. The opposite and the goal, I think, of the GBD is that the production of estimates will catalyze and reinforce the interest in new data collection, but certainly you all have a lot of experience that could also speak to this question. I think there's plenty that can be done in the production of estimates and communication of them that makes that worry not an important one, and certainly not one that would motivate us to not produce estimates. Very quickly on Raphael's comment with regard to identifying priorities for research. You remember, as perhaps others do, it's now been more than 20 years since the ad hoc committee on health research produced its report, so probably time for an update. And I think the direction of expansion of the GBD in terms of thinking about the burden and decomposing that into aspects amenable to existing technologies or requiring new technologies will bring us towards that.
Thank you. Natasha, 30 seconds.
Just perhaps one final comment to address a comment which came up before about the role of interpreting, going from the data, rendering it to information. I think, yes, that's a very important role, and a lot is being done also with the infographics. I think basically you're on the right track. But possibly, to address another comment, we could reflect a bit better also on how to improve the readability of some of the papers, because I think that there's a really important constituency out there, which are practitioners and frontline workers. And perhaps we need to be engaging also with them, because they can make a difference, and they often have the local knowledge, and we need to make sure that we move seamlessly from global to local in both directions, up and down. Thank you.
Thanks, Natasha. I would like you all to put your hands together and really thank all of the panelists and Chris. And Chris is now going to do a summary.
I'm not going to summarize, I'm going to close. And I'll channel my best Richard Horton by shouting, but I'm not Richard, so I won't shout. Nor will I be as inspiring or entertaining. You know, I think the last 2 days has been just tremendous. We have, you know, as a number of people have said, both in the sessions and in the discussion out there and in the poster sessions, the GBD has transformed into a family of people from around the world. And I'm happy to say, although not reflected in the panels, that we've passed the mark where more than half of the GBD collaboration is actually in low and middle income countries. And I think that's a trajectory that will only continue as we forge the way with this sort of new model. I tend to think of the sort of old discussion when I was in the UN system at WHO between things that were done centrally in New York or Geneva and things that were done in countries. And I think the GBD has found a space in between where there's a common set of methods and statistical rigor. And through this vibrant network has become really quite locally owned and locally produced. And we saw reflections of that in the session before this one, which I thought was amazing, from Public Health England to China to Brazil, and even here locally, examples of real use of the GBD to influence policy and decision makings. And it was just a smattering of the examples that we heard about. So I think, the GBD is alive and well. And we have heard lots of ideas about where we will potentially go. And as is the want of this family, we'll take constant feedback, both from within the community, within the family, and from critics from outside, and steer a course to try to continue what I think has been a really successful enterprise. I think of my favorite quotes. There were lots. We had Bill Gates saying the GBD is a beautiful thing. I'm definitely going to get a t-shirt made of that. We had, I think, probably one of the most, extraordinary statements of confidence in what we have become from the president of the World Bank, Jim Kim, saying that, for his second term of his presidency, his focus is going to be on his project around human capital, the Human Capital Project, the vision to drive ministries of finance and heads of state to invest more in people, in health and in education. And he's turned to us, the GBD model, to take that forward. And I think that's just really quite extraordinary, and a ringing endorsement of the vision that we've collectively crafted. Many challenges, lots of work to be done to achieve that, lots of dimensions to that, of course, but really quite extraordinary. And for us to start to think about all the different ways this database and the work that we've produced together can start to feed into other efforts whose ultimate goal is to improve people's lives is really motivating and exciting. And so I think we should be, really both pleased with where we've come together, that we've got a lot to do in the future, and I'm sure we're going to continue doing that, and that we will end up in places that we didn't expect, because we certainly did not expect when Alan showed those photos from 20 years ago and the 4 or 5 people that are here in the room from the original GBD, we certainly didn't expect to be where we are today when we started out. So I think lots of hope for the future. Now, I could go through and thank so many people for producing this event. And I wanted to start to compile a list of names of the teams at IHME that have worked on the logistics, on the communication, the really nice brochure that we had for the GBD 20th, and all the effort and of taking time to travel here, our speakers, our panelists, most importantly participants who found their own resources to get here. And I can't name you all. So I'm going to just say a huge thank you from us all, and that I do hope that maybe not in 20 years, maybe sooner, we'll have opportunity to come together again as a community, as a family, and celebrate even more as we go into, as Raphael said, this next exponential phase of growth. So thank you so much. Can't say how much we appreciate the engagement, commitment, and a particularly thank you to all our collaborators who really are doing extraordinary volunteer effort to make this a success. And we really prize that, appreciate it, and treasure it for the future. So thank you. Thanks to everybody.